It started with people before me and before Valerie. Sheldon Benjamin and Fred Offsu, who were senior members of the ANPA, again, American Neuropsychiatric Association, who had attended the BNPA conferences and connected with colleagues. So they suggested that we connect. And it so happens that I know Dr. Voon from the ANPA for a long time, so we connected in April 2021, a year ago. Then she told me that the BNPA is made of neurologists, nurses, psychiatrists, psychologists, rehabilitation specialists. This is very similar to the ANPA. Also, she told me that the BNPA currently is interested in reaching out to international audiences, and so is the ANPA. We talked about increasing interactions between the two organizations. And this past April, the BNPA asked us if we would be willing to contribute speakers to a session on neuromodulation during the annual conference. We said we would be honored to ask Dr. Shan Siddiqui, and as you heard from his excellent talk, we made the right choice. The BNPA made the session and today's day available to ANPA members for free. So we're doing all this in an effort to increase the relationship between the two organizations and collaboration and contact and interactions between members of the two organizations. We're going to be talking with the upcoming president of the BNPA about doing something together during March 2023 during the next session of the ANPA. So about Dr. Valerie Voon, she's a star. She had a research fellowship about in the NINDS, National Institute of Neurological Disease and Stroke, in the U.S. She is a long-term ANPA member, ANPA member. She was the chair of the Committee on Research and did a stellar job there. She has more than 230 peer-reviewed publications and an H-index of 74, which, for those of you who may not know, is the number of publications cited that number of times. So she has at least 74 publications cited at least 74 times, and many in the thousands. She's the current president of the BNPA, and Dr. Voon runs research groups across Cambridge and Shanghai and holds professorships at Cambridge University and Fudan University. She focuses on interventional psychiatry anchored on mechanisms underlying self-control and repetitive behaviors relevant to addictions and compulsivity. And her research group focuses on identifying anatomical and functional biomarkers sensitive to change to invasive and non-invasive techniques, leading to precision neuromodulation. So very much related to what Dr. Shan Siddiqui said. And Dr. Voon already introduced Dr. Shan Siddiqui, but just to stimulate conversation and to allow you to ask him questions other than his work accomplishments. His hobbies include creative nonfiction writing, chess. He's written a book, and he is a U.S. Chess Federation Class A. Sports, golf, basketball, table tennis, and cricket. Ask him about these. Playing and writing music, and technology. In terms of languages, he's proficient in English, fluent in Urdu and Hindi, semi-fluent in Spanish, and written in Arabic and Persian. Why so little? So please approach him with these as well as work-related topic. So thank you very much, and I hope that we could continue this collaboration between the two organizations, and we could talk with the upcoming president about BNPA members being able to attend the sessions of the ANPA next year. Thank you very much.
Thanks so much, Kayla. And that's actually worked really well because that's actually a live stream, so it's quite nice that we're able to do this in concert. So I am actually quite conscious of the time, so I think we might truncate questions at the very least for this. So it's a pleasure to be able to give this talk on precision intracranial stimulation for neuropsychiatry. I am going to talk about more neurophysiological components and the role of intracranial stimulation. So my group focuses on asking how do we optimize targeting and stimulation for addictions and compulsivity, but our approach is a little bit different. We use more theory-driven stimulation responsive biomarkers. So I'm interested in the underlying cognitive endophenotype. Some of it's been mentioned before, but I'm actually interested in mapping quite systematically intracranially across the impulsive and compulsive space. So there's a range of different impulsive constructs, and there's a range of different compulsive constructs. So really asking, how do we end up either repeating behaviors that are bad for us, or impulsivity, how do we end up making really rapid decisions that we later regret, or have difficulties in inhibiting responses. And we're also interested in the role of specifically negative affect and how negative emotion might actually influence and enhance impulsivity. And these cognitive endophenotypes bridge between brain and behavior, and we use multiple modalities to then investigate this. So most recently, we've been focusing on physiological biomarkers, but we also use imaging, and we also use computational modeling in the context of the cognitive neuroscience approach. And then we ask, how does this relate to intracranial and non-invasive neuromodulation? Can we use this to then parse out some of these questions and also use it to enhance and hopefully target therapeutic treatments? So I'm going to be focusing on deep brain stimulation, which, as many of you know, involves a small electrode that's inserted neurosurgically into either gray or white matter. And if you use high-frequency stimulation, you can then modify abnormal brain networks and also modify abnormal physiology. It's very effective for Parkinson's disease, for movement disorders. It's been FDA approved since 1997 for Parkinson's disease. More than 200,000 people have been implanted internationally and used particularly for movement disorders, but also FDA approved for obsessive-compulsive disorder in 2009. So why is this important in the context of neuropsychiatry? Well, we're actually interested mostly in targeting the refractory and the treatment-resistant patients. So I'm just going to give you an example here for obsessive-compulsive disorder, but it's certainly relevant in terms of refractory disorders for other psychiatric disorders like depression. So in this case here, obsessive-compulsive disorder, we know it has a 1.2% prevalence. It's a leading cause of disability, but critically, 20% of these patients remain treatment refractory despite multiple interventions, and that's the group we're interested in trying to target. So there's now actually there's at least 3 randomized controlled trial studies to show that deep brain stimulation for obsessive-compulsive disorder is effective using an RCT in the treatment of obsessive-compulsive disorder. Okay? So there is actually going to be a paper that will be published. There's multiple co-authors in this paper, and it's been aimed at Nature Medicine. It's just been accepted, and it suggests that these 3 randomized controlled trial studies provides Class A evidence for the use of deep brain stimulation for obsessive-compulsive disorder. Okay? There are multiple targets because, as we know, OCD is a network disorder. So the ventral internal capsule, the anterior subthalamic nucleus, and the med nucleus of the stria terminalis. So I'm going to focus in today on talking more about the subthalamic nucleus because I'm going to talk more about kind of underlying physiological substrates. And here, the subthalamic nucleus is a target for deep brain stimulation for both Parkinson's disease and also for obsessive-compulsive disorder. It's a very small nucleus that's found within the indirect pathway of the frontal striatal circuitry. And it receives these significant hyperdirect projections from motor, limbic, and cognitive systems. So even though it's such a small nucleus, it provides this kind of nexus for integration for motor, limbic, and cognitive substrates. So if you target, this is the STN, it's actually the size of a pea, but if you target the motor dorsal region, it's very effective for Parkinson's disease, and if you target the more anterior limbic cognitive region, it's effective for obsessive-compulsive disorder. Okay? And there's also preclinical studies suggesting potentially a role for, as a target for disorders of addictions. Okay, so this is what I'm going to be talking about, some of the physiological studies we've been running, and this is the process by which we gather the data. So I'll just walk you through the process itself. So in the context of deep brain stimulation, one can then record from these deeper structures, so from the electrodes or contacts that are found within the deeper structures. So in this case, the 4 contacts that are within the subthalamic nucleus, and we also have prefrontal scalp electrodes or EEG electrodes, so we can look at the relationship between prefrontal and also these deeper structures. And this is actually quite nice in terms of a very clean recording. And we can then time lock it to a cognitive process or a task that we're running. We can look at the underlying local field potential activity and look at the EEG activity. Now, the critical component is that we can also pair it with very precise time-lock stimulation. So in this case, of the right subthalamic nucleus, we've got a bipolar montage, and we can then deliver very precise pulses, a single pulse, multiple pulses, and so different frequencies, and we can time lock it to a specific process within the cognitive task. Okay, so our main question then is then to identify a physiological biomarker based on this cognitive endophenotype that's responsive to acute deep brain stimulation, and we can then move towards responsive stimulation, and this is particularly relevant for psychiatric disorders. So moving towards more closed-loop feedback stimulation for psychiatric disorders that we know are relapsing, remitting symptoms, and that you'd want to have the underlying physiology trigger the stimulation rather than have it on tonically. Okay, so I'm going to talk to you about 2 separate sets of studies, and we've been continuing in this kind of both these veins. So looking at risk-taking and looking at subjective emotion. And these are in collaboration with my colleagues at Ruijin Hospital, particularly Professor Bowman's-son. And these are students that are working with me both in Fudan or Shanghai and also here in Cambridge. Okay, so let's start with talking about risk-taking. But before we start, the subthalamic nucleus is most well known for its role in conflict. Okay, so when we think about conflict, and conflict is essentially looking at features that are very similar and trying to make a decision between something that's actually quite difficult because they're very similar in terms of trying to make a decision. You can look at different features, so really common the Stroop task, the flanker task. This is a common task called the random kinetics dots task. And there you see these dots that are moving randomly, and they have different coherence of either moving left or right. And you're just to make a decision, is it moving left or right? And as you're accumulating evidence, as you're trying to make a decision, the decision is actually really noisy. The accumulation of evidence to make this decision, is it moving left or right, is actually very noisy, until it crosses a decision threshold, at which point you execute the decision. So you say, okay, this is moving left, or it's moving right. And you can then capture this and model this using drift diffusion modeling. So you can get these computational parameters where you're picking up the decision threshold. So how much evidence do you accumulate before you make a decision, right? How impulsive are you? Or also drift rate, how quickly do you reach this boundary before you execute a decision? So it gives you an index of how much information do you gather before you make a decision. So it's sort of a marker of impulsivity, if you will. And we've done multiple studies looking at different forms of these decision-making tasks. And what you see is that in the context of conflict, and this is very well established, the STN is involved in adapting the decision threshold, so it increases the decision threshold, so it takes longer, you accumulate more evidence, and you also slow your responding. So it's putting on the brakes and saying, I'm going to give you some time before you, because it's a difficult decision, let's put on the brakes so you have some time to think about the process. And then obsessive-compulsive disorder does the same thing, but specific contexts. So specific to conflict and uncertainty, you get this increase in decision thresholds and slower responding, more so than healthy controls. And then the key component, and this has only been shown in Parkinson's disease so far, is that STN-DBS then decreases this decision threshold, so you actually respond much more quickly rather and to conflict. And so in that way, you might be perhaps a little bit less cautious, and that might be perhaps more adaptive for obsessive-compulsive disorder. Okay. So now we're going to switch to risk-taking. So this is risk-seeking. So this is trying to make a decision about outcomes that either result in a reward or result in a loss or something negative. Okay. And there's different ways that you can conceptualize risk-seeking. These are some of the tasks. The game of dice task, choosing between a sure choice or a gamble. And sorry, this didn't work out, but this is a series of cards here. And in all of these tasks, you're to weigh outcomes, the likelihood of a reward or the likelihood of a loss. And critically, in patients who've undergone deep brain stimulation targeting the STN, they actually become less risk-seeking, they're more risk-averse. So they choose a sure choice. So they're actually less impulsive, right? So I just shown you previously that STN-DBS is associated with greater conflict-induced impulsivity. In the context of conflict, they respond quicker. This one is actually decreasing impulsivity. So it's a different form of impulsivity, but you're seeing slightly different kind of heterogeneity coming out in terms of how impulsivity might respond in the context of STN-DBS. So it's actually an interesting question as to what's going on in terms of this form of impulsivity. Okay, so we went on to look at this. So here using intracranial recordings, and a task in which you show a card, and you're just to bet if the next card is higher, or you can choose not to bet. Very straightforward card drinking task. If you see a card like 3 and you bet, and the card is higher, you win money, or if it's lower, then you lose money. And so because you know the probability distribution of cards very well, you're actually going to be quite familiar with what you think the probabilities are of winning or losing. So what do you see in the EEG or the LFP? And what you're seeing here is specific to the outcome phase, and what you're seeing here is theta activity. So this is a time frequency plot. This is frequency here, 4 to 6 hertz is theta activity, and at the time of the outcome, you see this increase in theta activity. And the critical thing is that the people who bet more have greater theta activity as compared to those who don't bet as much. We then went on to ask, can we now modify this with time-locked stimulation? So we're just stimulating for 1 second within the subthalamic nucleus at the time of the decision phase, using 130 hertz, which is the clinical frequency for Parkinson's disease. And you see that, indeed, over the number of cards, people usually in blue decrease the amount of betting, and in red with stimulation, they become more risk-averse or more they pick the sure choice or choose not to bet. And they actually slow down in terms of their reaction time, so they're in fact less impulsive overall. So they slow down, but they also do make less bets. Okay, so we've been looking at this using computational modeling to try to tease this out a little bit further, because there's also a component of conflict that might actually be confounding this. Okay? So what we've been doing now is just looking at the context of high uncertainty, right, where there's greatest outcome variance. So you see these cards 4, 5, 6, and 7. They're more likely to be, they're very difficult to make a decision because they're actually almost random in terms of whether the outcome's a high card or a low card. But using drift diffusion modeling, we can separate out whether this is related to conflict or uncertainty. And before, we were always confounding conflict and uncertainty. But in this case here, we've been able to show that, so this is, for instance, low conflict. This is a threshold in drift rate. And when something has high conflict, you get this increase in threshold and a slower drift rate, as I'd explained earlier. But the key is that under high uncertainty, you actually see this opposite effect. So you can dissociate it between conflict and uncertainty. We see this lower threshold and this faster drift rate. So computationally, with this task, we've been able to show that this is related more to uncertainty and unrelated to conflict. So two different forms of impulsive type behaviors, but related to underlying cognitive processes that are dissociable. Now, what about the effect of physiology in the context of stimulation? So here we have STN stimulation at 130 hertz. We see this increase in theta activity after stimulation. So you can see this on the plot. The key thing is this relationship with drift diffusion modeling when we're looking at the correlation and the relationship between theta and this drift rate. And the higher the theta on stimulation, the lower or the more negative a correlation with the drift rate. So what it means is that the higher the theta after STN stimulation, the faster the drift rate towards the boundary of risk aversion, where they choose to not bet. Okay? So they're actually responding more impulsively, if you will, but it's actually towards a more sure choice. Okay, the safer choice or the more certain choice. And we think this is a feature of certainty rather than necessarily conflict. So just an interim summary in this. STN stimulation appears to hasten responding to conflict. It's a form of increasing impulsivity that's very well established. But what we're seeing is a different form of impulsivity emerging that's actually the opposite, that they're choosing a less risky choice. So it actually brings up a very interesting question and really highlights the heterogeneity underlying impulsivity. So what we've shown here is risk-taking under uncertainty, which has higher outcome variance, does actually differ from conflict, and we can pick that up using drift diffusion models. And critically, STN stimulation increases STN theta activity, and it shifts this relationship between theta and drift rates. So that under STN stimulation, you evaluate the evidence much faster, but you're choosing the safer, more certain choice. Okay? So we think that the STN stimulation might shift towards a choice to decrease the outcome variance or enhance certainty. So we still have a few more questions to ask in order to sort this particular question out. Okay, so in the last bit, I'm going to talk a little bit about subjective emotion. So this is, again, the same collaboration and, again, the same target. And there is evidence that the STN plays a role in terms of emotional processing. So in both Parkinson's and OCD, clinically, deep brain stimulation is associated with hypomania. So in Parkinson's disease, about 4%. In OCD, it has been reported in up to a third of patients. And it's actually very modifiable. You just have to change either the power or the medications or shift towards contacts that are more motor rather than limbic associative. You can do more systematic studies, which we and other people have done, where you switch on and off DBS. And on DBS has been shown to impair recognition of negative emotions and also to shift towards a more positive valence bias. So this has all been published, including work from my group in the past. And we then went on to also look at the literature on the physiology. So if you show an affective image, it's a very clear pattern that emerges. You get this theta activity very early on, and we're interested in this alpha activity here. So you get this late alpha desynchronization that occurs to the affective stimulus. And the critical thing is that that particular activity correlates with valence ratings and also with depression scores. It doesn't correlate with arousal, just with depression ratings, or with valence ratings. So we just went on to ask, can we influence emotional valence ratings by targeting this specific alpha desynchronization and using alpha-specific frequency stimulation of the STN in a brief manner? So we first just demonstrated that indeed we are seeing alpha desynchronization when we show someone an affective image. So indeed we do see this alpha desynchronization. And then we went on to ask, can we then modify that with stimulation? And so here, with a 1-second stimulation over the course of 2 different days, either at 10 hertz, so targeting the alpha activity, or at 130 hertz, which is a clinical activity. So we show the negative image either with stimulation or without stimulation or neutral. And again, this is the right subthalamic nucleus. And just to summarize the main findings, it's an interaction effect. And what you're seeing here is when a subject is stimulated at 10 hertz, they actually report the negative image as being more positive than it actually is. So they have a different experience when they're not stimulated, and it's different from 130 hertz, and it's specific to valence and not to arousal. So what we're suggesting is that the stimulation at 10 hertz of just 1 second is enough to actually shift how you might experience a negative image. So it's experienced in a more positive manner. And there's also a relationship with depression. So the more depressed you are, the more you experience this particular effect. So at 10 hertz, the 10 hertz stimulation, you get a more positive bias if you're more depressed. So we've gone on to look at this to ask what is the relationship between the stimulation and the actual underlying physiological frequency. So at 130 hertz, you continue to see this alpha desynchronization, so there's no change in underlying pattern. But at the 10 hertz, you lose this alpha desynchronization. And what this means is there's the alpha stimulation is actually facilitating or enhancing the power of the underlying alpha physiology. Okay? So you're losing this desynchronization, and indeed you end up with this increase in beta power, which is the frequency right next to it. Okay, so we think that this may be the reason that we were seeing the underlying behavioral change. So we have looked at this across a couple other substrates. So this one is actually looking at the habenula. The habenula is a very small substrate that is upstream of dopaminergic and serotonergic cell bodies. And in this particular set of studies, this was deep brain stimulation targeting the habenula, and this is for major depression. And running the same set of studies, what we saw was that to negative imagery, we see this alpha desynchronization specific to negative imagery. This is all in depressed patients now. And that it also correlates more with depression scores. I'm not going to talk about this last one. This is something that Saurabh Sankarsari, my postdoc, had presented yesterday during the poster session. This is looking at stereotactic EEG. So these are recordings in intracranial recordings across multiple substrates in epilepsy patients in amygdala, orbitofrontal cortex, and ventromedial prefrontal cortex, asking a similar question. And really just the take-home message is that we show this very nice top-down regulation of the ventromedial prefrontal cortex to the amygdala, whereas in the orbitofrontal cortex amygdala, it's bidirectional. Okay? So this very much kind of demonstrates and is proof of the what's been observed with resting state, with task-based fMRI studies, but we show that in the context of intracranial recordings. So it's actually quite a nice paper. Okay, so just to summarize, if I can get to the final slide. Okay, so just to summarize, we're really highlighting the heterogeneity of impulsivity, and we're in the midst of mapping out different impulsivity substrates, and here showing initially the STN stimulation appears to hasten responding to conflict, but it has an opposite effect on a different form of impulsivity, that of risk-taking under uncertainty, which using drift diffusion models we're able to dissociate very nicely. We see an effect of STN theta and the shift between the relationship between LFP theta activity in the STN and one of the drift diffusion models, and really shifting it towards a more certain safe choice. We also see this capacity for brief alpha frequency specific stimulation in the STN to then enhance and shift towards more positive emotional bias, possibly by decreasing alpha desynchronization. And we're in the midst of mapping emotional processing, right now using fairly basic questions, but we're in the midst of expanding this and looking this across a neural network with intracranial recordings. So we're using a lot of this intracranial physiology to then guide subsequent stimulation, both intracranially and also extracranially, to ask, can we modify specific cognitive processes and behaviors? Okay, and this takes an entire, I should add, so this is actually work we're doing across Shanghai and also in Cambridge. And I am just starting up a multi-center study for deep brain stimulation here in Cambridge, IOPPN, and also Oxford. And it's very much a multidisciplinary approach, and we'll focus in on mechanisms in a randomized controlled trial. So that's actually just kicked off and been funded. Okay, so very much a whole group approach, and I've been really grateful to my collaborators and certainly to my students who've been indispensable and absolutely brilliant.